Good morning, students. Today's topic will be extraocular muscles. So from the name you can tell where these muscles are present, that is surrounding the eyeball. So within the orbital cavity surrounding the eyeball, these extraocular muscles are present. We are going to see in detail about this extraocular muscles. First, the learning objectives. So from this PPT, what are the things we have to learn is the first is the names of the extraocular muscles. The next is you have to describe and demonstrate the attachments of the very important muscle, the Levator Palpebrae Superioris, and its nerve supply and action. And the third one is you have to read about the clinical importance of Levator Palpebrae Superioris. In short, we call it as LPS. And the next is describe and demonstrate the attachments of 4 recti and 2 oblique muscles. There are 4 rectus muscle and the 2 oblique muscles. And the last one is describe the actions. Actions are very important for these recti and the oblique muscles, and add a note on applied aspect. So these are the learning objectives you have to learn from this PPT. First is the basic classification of orbital muscles. Orbital muscles are basically classified into intraocular and extraocular. What is the intraocular muscles? Nothing but the ciliary muscles. Coming to the extraocular muscles, it is again divided into voluntary and involuntary. In the involuntary, you can see 2 muscles, that is superior tarsal muscle and the inferior tarsal muscle. Voluntary muscles are these. These are the muscles we are going to see in detail. In this class, we are going to see in detail about the voluntary group of muscles. Those are the Levator Palpebrae Superioris, superior rectus, inferior rectus, medial rectus, lateral rectus, superior oblique, and the inferior oblique. Coming to the extraocular muscles. Voluntary muscles. What are the voluntary muscles which I have said already? That is the 4 recti muscle, 2 oblique muscle, the Levator Palpebrae Superioris. These all comes under voluntary group of muscles, and these 2 comes under involuntary group of muscles. This picture shows the orbital cavity with the eyeball and the surrounding extraocular muscles. Here you can see the cut end of the very first muscle, the Levator Palpebrae Superioris. Beneath that, you can see the superior rectus, then the superior oblique, laterally present the lateral rectus, and inferiorly present the inferior rectus and the inferior oblique. So you can see all the extraocular muscles. As the Levator Palpebrae Superioris muscle, we are going to see in detail the origin, from where it takes its origin. It takes origin from the undersurface of the lesser wing of sphenoid at the apex of the orbit above the common tendinous ring. And insertion, it is divided into 3 lamellae: the upper lamellae, intermediate lamellae, and the lower lamellae. Upper lamellae is inserted into the skin of the upper eyelid. All other recti muscles and the oblique muscles gets inserted into the eyeball, but this Levator Palpebrae Superioris muscle only gets inserted into the eyelid. Okay, the intermediate lamellae gets inserted into the superior tarsal plate, and the lower lamellae into the superior fornix of the conjunctiva. In this slide, you can see 2 pictures showing the cranial cavity of the skull. So you know the cranial cavity is divided into 3 parts: the anterior, middle, and the posterior cranial fossa. So they have shaded in 3 different colors. You concentrate on the pink shaded bone, that is known as sphenoid bone, which I am going to tell in detail. So you will be knowing the parts of the sphenoid bone: the body, the lesser wing, and the greater wing of sphenoid. They have marked very well in the picture the lesser wing, greater wing, and the body of the sphenoid bone. That is where is the hypophyseal fossa is present. That is the body of the sphenoid bone. In the next picture, They have shaded only the lesser wing of sphenoid bone, which I want to tell you now. Why? Because this Levator palpebrae superioris muscle, which I've said already, takes origin from the undersurface of this lesser wing of sphenoid bone close to its apex. So just to show the origin of the Levator palpebrae superioris, I discussed about the sphenoid bone. Here you can see the two pictures, and one picture showing the orbital cavity and the extraocular muscles. There I have marked the Levator palpebrae superioris muscle. So that is the entire Levator palpebrae superioris muscle, and in the next picture you can see the insertion of Levator palpebrae superioris muscle. The next is the action, nothing but the elevation of eyelid. Action of LPS is nothing but elevation of eyelid. Nerve supply is supplied by oculomotor nerve, which is the third cranial nerve. And the clinical importance is very, very important in Levator palpebrae superioris, because paralysis of this muscle due to the involvement of oculomotor nerve causes complete ptosis. What is complete ptosis? Nothing but drooping of upper eyelid. Drooping of upper eyelid, we call it as complete ptosis. And lesion of cervical sympathetic chain, as in Horner syndrome, leads to partial ptosis, as it affects the smooth muscle of the LPS. So there are two types of ptosis. One is complete ptosis and another one is partial ptosis. Yeah, this is the classical picture showing the paralysis of LPS. The condition we call it as ptosis due to involvement of oculomotor nerve. There is paralysis of LPS. So there occurs the condition called as ptosis, the drooping of upper eyelid. Next, we are going to see about the recti muscles, the four recti muscle. First, we are going to see the origin, from where these recti muscles are taking its origin. So, it takes its origin from the common tendinous ring. So, we'll see what is common tendinous ring. The next picture, you can make out the orbital cavity with the cut end of recti muscles. So, all the recti muscles, you can see the cut end of it, and you can see the origin. So its origin is circular in shape. That is the common tendinous ring. So this common tendinous ring will be enclosing the optic canal. This optic canal gives, or the optic nerve passes through this optic canal, and you can see the cut end of the optic nerve. So that is the optic canal. So the common tendinous ring is surrounding the optic canal. The common tendinous ring is otherwise known as annulus of Sin. Yes, in this picture it's very clear. This is the common tendinous ring from where all the recti muscle taking its origin. Only the recti muscle, not the oblique muscle or not the LPS. Only the recti muscle takes origin from this common tendinous ring. Here you can see a schematic diagram. This L-shaped fissure, we call it as superior orbital fissure. Okay, this is known as superior orbital fissure, and this round ring is the common tendinous ring. You can see the cut end of the muscles also, and this will be the optic canal. This common tendinous ring will enclose the optic canal, as well as it comes to the middle part of the superior orbital fissure. Can you make out this L-shaped fissure, superior orbital fissure? This common tendinous ring is approaching to its middle part of the superior orbital fissure. So this is the attachment of the common tendinous ring. Why I am talking in detail about this common tendinous ring is it takes all the recti muscle is taking origin from this common tendinous ring. But this lateral rectus alone has got two heads. one head is taking origin from the common tendinous ring and other head is taking origin from the adjoining greater wing of sphenoid also. Yes, coming to the insertion. So, you know the origin of the recti muscle. Now, we are going to see the insertion of the recti muscle. Here, this is the eyeball and you can see the superior rectus, medial rectus, lateral rectus and the inferior rectus. All are getting inserted into the eyeball posterior to the limbus. So, which is limbus? Limbus is nothing but the junction where the sclera and the cornea. This is the cornea, isn't it? The sclerocorneal junction, we call it as limbus. So just posterior to the limbus, in front of the equator, the recti muscle gets its insertion. So limbus is nothing but the sclerocorneal junction. So now we are going to see about the oblique muscle. So we have seen about the recti muscle. Now we are moving on to the superior oblique muscle. In this picture, this is the picture of the orbital cavity where you can see all the muscles and the eyeball. Here you can see this is the medial part and this is the lateral part. Here only will be the medial wall of the orbit. Now we have removed the roof of the orbit and here you can see where I am keeping the pointer in the medial aspect. You can see a muscle which we call it as superior oblique muscle. Though it is superior, it will travel in the medial aspect only. Superior oblique muscle. So you should know from where it is taking its origin. So this superior oblique muscle takes origin from the undersurface of the body of sphenoid bone. So already I have said which is body of sphenoid bone. So it's taking origin from the body of sphenoid bone medial to the optic canal. Here this passage is the optic canal. Just medial to the optic canal, this oblique muscle takes its origin. Okay, it travels along the medial side of the orbit. Then here you can see a pulley which anchors the superior oblique muscle. Yes, this pulley we call it as trochlea. So it winds around the trochlea at the superomedial part of the orbit, then turn towards the eyeball and gets inserted behind the equator at the posterior superior quadrant of the eyeball. This is the insertion of the superior oblique muscle. So you can see the entire muscle. And here you can see the LPS has been cut. Below the LPS you can see the superior rectus. Okay, on the medial side of the LPS you can see the superior oblique. In this picture it's very clear. This is the superior oblique muscle. You can see the trochlea. It is winding around the trochlea and getting inserted behind the equator at the posterior superior quadrant of the eyeball. Next is the inferior oblique muscle. Here, this is the inferior oblique. They have showed in the arrow. This inferior oblique takes origin from the maxilla. So this is the maxilla bone. This is the orbital cavity and this is the maxilla bone. From the orbital surface of the maxilla, this inferior oblique takes its origin, passes backwards and laterally below the inferior rectus, and where it's getting inserted again behind the equator, just parallel to the superior. Here is the superior oblique and here is the inferior oblique. Just below the superior oblique in the posterior superior quadrant, the inferior oblique also gets its insertion. So you can see the inferior oblique muscle. These insertions are very, very important. With this insertions only the action of muscles will be related. Coming to the actions, very, very important. If you see this action of the extraocular muscles, that to the the 4 recti and the 2 oblique muscle. We are going to see the action of it. This is the eyeball, and this will be the medial side, and this will be the lateral side. This is the medial side, and this will be the lateral side. So first muscle which we are going to see is superior rectus. So what are the action of superior rectus? Okay, so you can see the arrow moving upwards. So it does the elevation. This is the medial side, isn't it? So if the arrow pointing towards the medial side is adduction, and you can see the arrow pointing downwards medially. Okay, it rotates the eyeball medially. This arrow shows the rotation of eyeball medially, that we call it as intorsion. So these are the 3 actions which is done by the superior rectus. So the up arrow is the elevation, the arrow showing medially is the adduction, and this arrow denotes intorsion. Okay, and this muscle is the medial rectus. This arrow again the adduction. So the only action performed by the medial rectus is the adduction. Coming to the inferior rectus, the arrow is pointing downwards, and one more arrow is medially, and another arrow is rotating the eyeball laterally. Okay, so now this arrow is pointing medially, so it does depression. This arrow is showing downwards, it does the depression. Medially is adduction, and moving the eyeball laterally, so we call it as extorsion. If the eyeball is moved medially, it is intorsion. If it is laterally, we call it as extorsion. Okay. Yes, we have completed the 3 recti muscle. Now coming to the lateral side. So medial side is over. We are moving on to the lateral side. So if the eyeball moves towards the lateral side, we call it as abduction. Okay. So the first here, if you see, the inferior oblique is above and the superior oblique is below. Though it is superior, its action is below only. So we are drawing it below, and the inferior oblique, though it is inferior, its action is in the superior aspect. So we have kept it superiorly. First is the inferior oblique. You can see the up arrow and the arrow pointing medially, and the arrow turning the eyeball laterally. So it does elevation, abduction and extorsion. So it's the action of inferior oblique. Lateral rectus, that's the only action. The arrow is pointing laterally, so it is abduction. Coming to the superior oblique, see the arrow it's pointing downwards, so it's depression, laterally abduction, and it is rotating the eyeball medially, so it is intorsion. Yes, so these are the action of the recti and the oblique muscle. So in the next slide, we are going to see what are the primary action, what are the secondary action, what are the tertiary action. So in this tabular column, you can make out what are the primary, secondary and tertiary action. Before we saw all together, now we are classifying into primary, secondary and the tertiary. You can have a look on the tabular column. So here I want to just tell 2 points, the superior oblique and the inferior oblique. Since the muscle is obliquely present and its insertion is somewhat different, you can make out its primary action is intorsion and the extorsion. Moving on to the next slide. So we have completed the actions. Now we are going to see about the nerve supply of the extraocular muscles. All voluntary extraocular muscles are supplied by the oculomotor nerve, which is the 3rd cranial nerve, except lateral rectus, which is supplied by abducens nerve, which is the 6th cranial nerve, and the superior oblique supplied by the trochlear nerve, which is the 4th cranial nerve. So we are giving a mnemonic as LR6 and SO4. So in this picture, we are going to see the nerves. Here you can make out the oculomotor nerve, which is entering the orbit, and you can see it is dividing and supplying all the extraocular muscles except the lateral rectus and the superior oblique. If you see this lateral rectus, it is supplied by the abducens nerve. So you can see the abducens nerve, and this will be the trochlear nerve, which is going and supplying the superior oblique muscle. Till now we have seen the nerves of the extraocular muscles in detail. Now we are going to move on to the clinical aspect of the nerve supply of the extraocular muscles. Now in this slide you can see a picture of a boy where his eyes are not aligned properly when looking. So this condition we call it as strabismus, otherwise known as squint. What is it? It is nothing but a unilateral paralysis of an individual recti muscle due to the involvement of the corresponding nerves which is supplying the corresponding muscles. So this condition we call it as strabismus. So it has got two varieties, that is the medial squint and the lateral squint. In the medial squint, the muscle paralyzed will be the lateral rectus and the nerve involvement is the abducens nerve which is supplying the lateral rectus. In the lateral squint, the muscle involved will be the medial rectus and the nerve involved will be the oculomotor nerve which is supplying the medial rectus. So due to the involvement of these nerves, the corresponding muscle, the medial rectus and the lateral rectus, gets paralyzed, and finally the patient will be landing up in a condition known as squint or strabismus. Thank you for listening to this presentation very patiently, and I hope this presentation will make you to understand the anatomy well. Thank you.